Good morning, everybody. This is Kim Bimsteffer. I've got 10:01 on my watch, so why don't we get started? So I am honored to help co-host, along with our Lieutenant Governor today, a wonderful EDI session, or Equity, Diversity, and Inclusion session, that will be recorded today and shared with all state employees. And the session today is Women in America Healthcare Promise and Problems. Our keynote speaker is Dr. Patty Gabow, Dr. Patty Gabow. So Lieutenant Governor and I will co-host this today. The order of our day will be listening to our keynote speaker after we hear her formal introduction. And then after she speaks, I'll share about 4 slides to compare her national statistics to Colorado statistics. And you'll be happy to know that we are doing much better than the nation in women in healthcare leadership. Then we'll open it up for Q&A. If you want to ask a question, you please use the Q&A function, if you will. And then, while you're thinking about your questions and putting that in the Q&A function, Lieutenant Governor and I are going to ask our keynote speaker specific questions, and I might surprise the Lieutenant Governor because she is such a rock star as well by asking her some of the same questions. So we'll get to hear some of her wonderful insights and input as well. So with that, I want to thank, we have several departments that we have invited here, so you are in good company. So Healthcare Policy and Financing, DPA, CDPHE, or Public Health and Environment, CDHS, or Human Services, and the Office of Saving People Money on Healthcare. So we're in good company. We hope to have a good crowd today of both women and men, so everybody is learning about each other, and we're helping make this a Colorado for all, or a Colorado that works for all. So again, this is a wonderful EDI opportunity as we work to do just that. So with that, I'm going to turn it over to our Healthcare Policy and Financing's committee chair for our EDI work, and that is Committee Chair Sharla Williams. Sharla, over to you. Please turn on your mic and your camera.
Thank you, Kim. Good morning, everyone. So I'm gonna go ahead and read Dr. Gabow's intro. Dr. Gabow spent her medical career at Denver Health, ultimately as CEO for 20 years, retiring from that position in 2012. She's a professor emerita of medicine at the University of Colorado School of Medicine and a master of the American College of Physicians. She has authored over 170 articles and books, book chapters in 2 books, including most recently, Times Now for Women Healthcare Leaders, A Guide for the Journey. She was a founding member of the Federal Medicaid and CHIP Payment and Access Commission, and currently serves on the Robert Wood Johnson Foundation Board of Trustees and the Loan Institute Board Chair. She has received numerous awards, including National Academy of Medicine Gustav O. Linhart Award, AMA Nathan Davis Award for Career Public Servant, the American Association of Medical College David E. Rogers Award, and the NCQA Health Quality Leader. She is a member of the Manufacturing Excellence Hall of Fame, the National Academy of Social Insurance, and the Colorado Women's Hall of Fame. She is a graduate of Seton University and the University of Pennsylvania School of Medicine. She is board certified, in internal medicine and nephrology. So I'm with extreme pleasure, I'd like to pass it over to Dr. Patty Gabow.
Good morning, everybody, and thank you for inviting me. And Ms. Williams, thank you for that kind introduction. Before we begin, let me explain my voice. I have spastic dysphonia, which means I have a twitch in my vocal cord. The treatment is Botox, and sometimes when I get it, my voice gets very breathy. Don't worry if you don't hear a word. Everything important is on the slides. Before we begin to talk about women in American healthcare, we have to remember that next slide, please. That healthcare is embedded in our culture and our society. So we have to start there. When this bold experiment in democracy began, it was declared that all men are created equal, and that meant white men. It took 150 years for women to be included in that democracy. And shortly after suffrage, an Equal Rights Amendment was proposed to the Constitution. It took Congress 50 years to approve the ERA, and it is still not a constitutional amendment. In the early 60s, it became clear that women did not receive equal pay for the same work, and the Fair Labor Standards Act was amended to require that. But still today, women do not have equal pay. Women in the United States have less gender equality than many other places in the world, as is shown by this study from the World Economic Forum, which looked at education, health, the economy, and politics. And we ranked 45th. With that brief look at society, let's turn to healthcare and look at women as recipients of care, caregivers in the workforce, and as leaders. When we think about care for women, we need to look at conditions that are unique to women, how they are treated for common diseases, and what is their access to medical breakthroughs. Perhaps the single most important lens with which to view how women are treated in society and in healthcare is to look at how they are treated before, during, and after pregnancy. Let's look at maternal healthcare. This is a mixed story. In the 1900s, 850 women per 100,000 live births died in childbirth. We made remarkable strides in the early 1900s, and by 1987, that number was 7.2. But then something went awry, and now we are at 17.4 deaths per 100,000 live births. In fact, we have the worst maternal mortality of all high-income countries. And that 17.4 figure belies the fact that there's enormous variability by race and geography. Black women and Alaska Natives and American Indians have 2.5 to 3.5 times the maternal mortality and 5 times the maternal morbidity. The geographic variability is amazing. California does the best with 4 deaths. Colorado is among the best with 11.5 deaths. The 5 worst states have maternal mortality ranging from 37 to 58 deaths per 100,000 live births. That's equal to the maternal mortality in Vietnam and Jordan. Quite shameful. What about common diseases? Heart disease being the most common. And women are underdiagnosed. They're less likely to see a cardiologist, to receive evidence-based care, to have pre-hospital diagnosis, to receive reperfusion, or to receive a heart transplant. Ironically, they are more likely to be a heart transplant donor than a man. What about access to medical breakthroughs? Well, for decades, women were excluded from all clinical trials. The reasons given were women could be pregnant, so the fetus could be affected. Women have hormonal variation as a confounding variable, therefore requiring bigger study populations. And of course, most of the researchers were men. This failure led to failure to address conditions unique to women, like pregnancy or more common conditions in women. It also led to failure to address the different response to conditions or drugs in women. And women are not biologically or physiologically men. In fact, 7 of the 10 drugs withdrawn by the FDA between 1997 and 2001 had a bigger negative effect on women than men. As we look at breakthroughs, we need to look as women as research subjects. And this actually is a good story. In 1986, the women in Congress said, wait a minute, and they demanded that Congress and the NIH include women in all late phase clinical trials. Shortly after, the Office of Women's Health was established at the NIH and the Women's Health Initiative, and this was very important. They did studies like the effect of postmenopausal estrogen and led the development of the HPV vaccine. And in 1993, NIH mandated the inclusion of women in all NIH clinical trials. And in 2015, NIH said sex is a biologic variable. Now that may sound funny, but what it meant was that sex had to be included in all studies, whether you were looking at cells, animals, or people. And by 2017, 50% of participants in NIH-supported research were women, although there is some variability across studies. We also need to look at women as researchers. If we look at the University of Colorado Center for Women's Healthcare Research, 41 of the 61 investigators are women, suggesting that women investigators are much more likely to look at women's issues than are men investigators. And of course, grants are important. 33% of NIH grants are awarded to women. This has been a 10% increase over 20 years. Let's turn to women as caregivers. Women are much more likely to make healthcare decisions for their families. They make 80% of those decisions. And women are much more likely to stay home with a sick child than a man. Also, women are much more involved in caring for seniors in the population. On average, women physicians with a male spouse or partner spend 8.5 hours per week more on parenting and domestic activity than their male partners do. Let's look at women in healthcare. This shows the gender distribution of women in the top profession. Women make up 88% of the nurse practitioners and 86% of the nurses, 95% of the midwives. The only three professions where women are not the majority are physicians, dentists, and EMTs or paramedics. Now, this shows how this looks across the profession. Women are 83% of the frontline healthcare workers, but only 30% of the C-suite. And in the C-suite, they are less likely to be the CFOs or the COOs, and even among nurses, where women are the majority, women are only 60% of the CNOs and only 13% of the CEOs. The crosshatch area shows how many women would have to be added in order to create equality in these leadership positions. Only 22% of the boards of Fortune 500 healthcare companies are women, and only 30% of the boards of healthcare companies. And in 2020, men held the leadership positions at HHS, NIH, CDC, the VA, and Surgeon General. Now we have a woman heading the CDC. So why should women lead? And I think there are three answers to that question. American healthcare has major problems, and we need everybody at the table to solve them. Secondly, it's an issue of straightforward fairness, and women add valuable skills and essential perspectives. America has major problems in cost, access, outcomes, and disparity. And yet, this is what the tables of leadership have looked like for decades. And I would say we need, if we have the same people at the table, we are going to get the same results. We need diversity at the tables of healthcare leadership. We need men and women, white individuals and individuals of color, seniors and young people, and people with disabilities. Different leaders with different perspectives will yield different results. I would posit better results. And we need fairness at the tables of leadership, and fairness demands equality, and equality demands equity. With equality, we all are having the same bicycle, but in point of fact, the only person who can ride that bicycle will be a man. But with equity, everybody gets the size and type that they need to succeed. By creating equity, we will level the playing field. And we need to do this with childbearing in order to get paid maternity